Hello, Ivan, are you there? Ivan Bozjak. Can you hear me? Can anybody hear me in the panel? Can anybody hear me in the panel?
Hi, John.
I gotta make sure my audio is okay. Can someone tell me if they can hear me? Perhaps not. Hello, William, can you hear me? Oh, okay, you can hear me, William. Okay, perfect, okay.
Yes.
Thank you for the feedback. We'll be starting in about 25 minutes. We start in 17 minutes. Hello? I'm sorry? Hey, how you doing, Saeed? Okay, I'm about, Saeed, excuse me, I'm about, Saeed, excuse me, I'm about to do a show now. Oh, good. Oh, good. Come on, I talk to you then. Bye-bye.
Hi,
Hey, Saeed.
how are you? Best. Yes, I'm here.
Okay. Hey, Saeed, how you doing? Can you hear
Fine,
me?
and you? Yes, yes,
Can you hear me?
yes. You hear me? Do you hear me, John?
I can't hear you. I can't hear you.
Okay.
Can anybody else hear me? Can anybody else hear me?
I can hear you as well.
Yeah, William, you said perfect before. How about now, William? Is that okay? Saeed, I can't hear you. I can't hear you. You're mute.
Yes, I hear
Yeah,
you.
I don't know
I'm
what's
mute.
going on here. Can anybody
Yes.
hear me? Can anybody hear me?
Yes, it's okay.
Can anybody hear me?
I hear you.
I heard you.
I'm getting feedback.
Yes, I think it's okay, John.
It's okay.
Testing, 1, 2, testing.
Can you hear now? Can you hear now?
Yes,
Is it
yes,
different
yes,
now?
yes.
Yes.
Testing. Can you hear now? Can you hear now? Can you hear
Yes.
now? No. Can you hear now?
Yes, 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 yes.
Can,
Yes.
Can anybody hear me? No.
Yes.
Yes. Clear.
People can't hear me.
Yes.
Yes.
Oh, Lord.
It's a technical problem.
What the fuck happened? Wait a minute. Wait a minute.
Okay.
Can anybody hear now? Can you hear now?
Yes,
Oh, good, good.
it's fine. It's fine.
You know what happened? My cord broke.
Yes.
I don't know how it just broke. It
I
was strange.
suspected that, but you can harass.
Yeah, it was unusual. I said, "Why isn't my microphone working?" I was checking the settings, but then I look at the cord; it's cut.
Okay. That's
Yeah, we
good.
can hear.
Hmm.
Hey, excuse me, sorry. We'll talk. Let me get off. Yeah. Okay. No, you can hear me. Okay now, right?
Yes.
Oh,
Yes.
okay.
Yes.
Good. Okay. Takashi, are you here?
Hmm. Takashi is not here.
Okay.
Isn't here.
Ivan, are you here? Ivan Boshnak,
Yes.
the
Yes,
presenter.
yes, I'm here.
Oh, how you doing?
I'm doing well. How are you?
Good, good. Your camera's not on there.
Well, I didn't turn it
Okay.
on.
Yeah,
Hi,
yes, how you doing? Nice to meet you.
nice to meet you.
Do you know how to screen share?
Yes, yes, I can see
Oh,
share screen.
you're a
Let me
pro,
see.
huh?
Let me check it.
Okay, yeah, let's run through it. Have you done it?
Can you see the presentation?
Yeah,
Just a
yeah,
sec.
yeah. Go, make it larger as you. Yeah,
Okay.
you know what you're doing.
Yes, of course.
You can tell.
Yes, this is the presentation. Okay, great.
Looks nice. Looks nice.
Thanks.
You young kids are fast.
Are we?
Okay, Slaven hasn't arrived yet.
He will probably half an hour earlier, I believe. I heard I talked to him yesterday.
Oh,
He'll
okay.
probably be in about 15:30.
Yeah, he's not. You're in Sarajevo. Where are you now?
No. I'm in Zagreb.
Oh, Belgrade.
No, Zagreb, the capital of
Oh,
Croatia.
Zagreb. Oh,
Yes,
Zagreb. Yeah. That's where the university is, right?
Yes, of course. That's where I finished the medical school, and this is also the place where now I am a neurosurgery resident.
What year are you, Ivan?
Second, going on third soon.
Okay. And Saeed, the gentleman next to you, is a neurosurgeon from Reunion Island, off Africa.
Great, nice
Yes,
to meet you, Dr. Saeed.
Nice to meet you too. How
Yeah,
are you?
I'm feeling good.
Yes.
Prepare the lecture. Hope it will be good. I will tell you at the beginning what will be the themes. We will start from classical treatments going on to the new treatment modalities.
Okay.
So we can also remember temozolomide and
Yes. Okay.
current
That's
treatment.
great. Yes. Ivan,
Yes.
do you know a neurosurgeon, Vesna Yazanovic? No.
Sorry, what's his name?
Vesna Yazanovic.
Vesna. No, I don't know him.
No. Okay. Okay. It was in Paris in 19. Yes, 19. Yes, 19.
1990 some.
Yeah.
Mhm.
Well, I hope, Ivan, I hope this is a national holiday in Croatia because of this presentation.
Well,
Yeah.
not yet. Maybe some other time it will be, but it's the first time.
Maybe next week.
Yeah, maybe it will be a 7-day holiday.
Okay, we're starting in 1 minute. Okay. Yeah, I'm gonna mute everybody.
Wait,
but
just a second, just a
Yes,
second.
yes.
yeah, okay. Just let me know.
Let me just check something. Where is Slaven?
Yeah, sure. It's
Uh,
okay. That's okay. We can start without him. I think he
Mhm.
mentioned that he may.
He 4 p.m. You wrote 4 p.m. Now
Whatever.
it's 3 p.m.
Whatever.
Doesn't matter. I will call him. Maybe he's.
Okay.
Give me just 1 minute.
Okay, if he's gonna come, I'll wait.
Okay, if not, we can start.
Okay. So see what he says, and if,
Mhm. Slaven says he will be here in 3 minutes.
3 minutes.
Mhm.
Okay. Well, let's have a vote of the panel. This is like the thumbs up or thumbs down in Rome. Okay. Should we let the gladiator live or die?
I will prepare the presentation.
I tell you, I'm a big fan of Roman history, Greek history.
Yeah.
Oh yeah, I love that. I love that. When I was a kid, I always loved that. When I was a kid.
I like the Egyptian history.
Oh, you like
But-
Egyptian?
Yeah, but Rome also seems interesting.
I don't know it as well as the other, as European. You know, in America, a lot of our education is mostly European. It's not other parts of the world. You know what I mean?
Yes, I heard that. For example, in our education system, we actually learn quite detailed about Roman history, Greek history, even about USA history. So actually, we are our school system is, I would say, pretty wide.
Yeah.
Pretty, you have in high school, you have 15, 16 to 18 subjects from art to music to sports education, but I think that's not the same system in America, but well, we can discuss which system is better, but
well,
America is more innovative, definitely.
I didn't realize it until I went to Canada when I was in 8th grade,
Mhm.
and saw the way they taught history. It was different than America, which was just over the border.
Yeah.
The different slant. And not that it was just different. It was more worldly and not aimed at mostly European. It was China. It was other. We didn't get much education at all, really, in the China, Japan, the Far East. So it's more. I don't know what it is like now. I have no idea what it's like now. But it wasn't really bad. But I mean, I could see a difference. But
Well, as somebody said, self-education is the most important. I believe in that.
Yeah, I'm going to get you off the screen share to introduce you when Slaven comes. Okay, I'm going to boot you off the screen share. So, yeah, I think you're going to like this platform. I'm meeting the top neurosurgeons in the world, and I'm not especially qualified to meet them. Only guy knows Zoom. That's the only reason.
But I believe this platform is really good, not just for connections, but to expand knowledge, to definitely see how other people are doing, what can be done better, what can't be done better.
Yeah, we want to hear what's going on in Croatia. We heard what's going in Russia. We want to hear from all parts of the world how they do things.
When I researched this subject, I also researched what do we do in Croatia. Do we use new treatment drugs? Right, you will hear about proton beam therapy. Unfortunately, we don't. We actually have classic gold standard system with temozolomide and radiation.
Yeah.
But there's FDA in USA, for example, approved bevacizumab drug, for example, for aggressive glioblastomas, recurrent types. So yes, that is different. Oh, at the end, I think it's all about the financials. Is it worth it for the government to pay it? Because for example, our healthcare system, I'm also very interested in healthcare development, and our healthcare system is quite different from United States or England healthcare system. For example, our healthcare system is mostly paid by our government.
Excuse me, Ivan. The star has arrived.
Here he is.
We have Trump. We have trumpets. The trumpet players have the weekend off. So, Slaven, how you doing?
Hey, John.
We can't hear your voice very good, Slaven.
Is now better?
Yeah. Okay, Slaven, you ready to go? You introduce Ivan, and away we go. Okay.
Of course. Just
okay.
continue.
Okay.
Thank you.
Just give me a minute. Just give me a minute. 10, and I'll start, and I'll introduce you. Okay.
Okay.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. Today, we're honored to initiate the Croatia Neurosurgery Grand Rounds and to welcome back an old friend to moderate, Slaven Golkovic. Okay, Slaven, welcome. It's all yours.
Hello, everybody. I'm really happy that Dr. John Bennett, Dr. Ivan, and me made this presentation today because it's great to be back. What can I say? I mean, I finished med school and did some things, so I'm back on the train. And I would love to introduce Ivan Bošnjak, MD, who is a neurosurgery resident for Sisters of Charity University Hospital Center in Zagreb, Croatia, which is the capital. He's my friend for a long time and a dedicated professional who has a background both in medicine and in economics. So I think he will give you really an outstanding talk about these topics, but based on modalities, newest modalities in treatment of glioblastoma. So I'd like to give the stage to our real star today. Thank you, John. Really great to see you.
Thank you, Slaven, for this nice introduction. Thank you, John, for organizing this platform. If you all agree, I would like to start with our lecture. Let me press share screen and tell me if you can see the presentation.
Okay.
Do you see it?
Yeah. Yes. Perfect.
I can see it fine. Thanks.
Okay. So my topic today will be newest modalities in treatment of glioblastoma. So what we will do, we will start very shortly with history of glioblastoma, which is quite interesting. The first time neuroglia cells were actually mentioned was in year 1859 by Rudolf Ludwig Virchow. He was the first one that discovered them and connected them with gliomas, and then separated them into low and high grade gliomas, which are very important today. In 1981, another researcher, Leeuwenhoek, described the function of glial cells, giving them support to neurons. Neurosurgeons are first mentioned in 1926, when Bailey and Cushing took 256 histologic specimens and looked what is the difference in each specimen. What do they have in common and what is the main difference? And they found out that there is a distinct part of some specimens, human brain specimens, and they called it spongioblastoma multiforme. So actually glioblastoma, first name was called spongioblastoma multiforme. In 1940s, actually, the spongioblastoma multiforme became known as glioblastoma multiforme, as we know today. As we all know, this is Harvey Cushing, the father of neurosurgery. And this guy on the left side is Virchow. He was a very interesting person. He was not a neurosurgeon, but he was a father of modern pathology and was really influential in the field of medicine. He was not only a pathologist, he was also very, very important in social medicine. He was very, very important in typhoid fever. He was very important, for example, in defining leukemia. As you all know, Virchow-Robinson spaces in brain. So I put his picture because he was really detrimental in medicine in those ages. And also very interesting about him, he was against evolution. So he was very, very against Darwin. And actually, that is very interesting when you see some famous scientist, someone who has contributed very much in one field. Maybe he was more in conflict with the current political and social situation in the other spheres. On the right side, we have classical MRI of glioblastoma, which we will discuss today. Main thing when researching glioblastoma is from histologic and pathophysiologic standpoint, we have 4 histological types of tumors. We have classic, mesenchymal, proneural, and neural types. Now, why is this important? Because all these types are glioblastoma, but they have different genetic mutations or alterations. Also, some mutations of glioblastoma are important from prognostic point of view, like isocitrate dehydrogenase and 1pq19 chromosome deletion and MGMT mutation. It is called actually methylglutaril methyltransferase mutation. We have wild type versus normal type. Wild type is usually the normal type, while the others are mutated types. And these are important in current treatment modalities, as you will see with temodal or temozolomide as current gold standard chemotherapy treatment. The very other interesting stuff is that glioblastoma are actually primary or secondary from their origin. For example, primary glioblastoma is glioblastoma that is the same tumor type from the beginning and is more aggressive than secondary glioblastoma, which is actually progression from glioma stage 1, stage 2, stage 3, and then invasive stage 4 glioblastoma. Why is this gradation important? Because gliomas grade 3 and 4, in which glioblastoma multiforme are very invasive in local tissue. So actually, when we can see, for example, on this picture here, okay, the tumor is seen here from MRI, but the characteristics of glioblastoma is that he gives secondary or locally metastases that cannot be spotted on MRI. So that is why the treatment of glioblastoma is very, very hard and challenging. Let's make a little digression about isocitrate dehydrogenase. This is an enzyme that, if you remember, is in citric acid cycle or Krebs cycle. Krebs cycle is important cycle in the human cell because it is in mitochondria and is important in production of energy. So if we have the mutation of isocitrate dehydrogenase, the product is not alpha-galactoglutarate that goes in the other parts of Krebs cycle, but mutant type dehydrogenase type of molecule, which is its pathophysiologic effect is actually that it travels to the nucleus cell and interferes with normal cell gene function. So this is we have actually three types of isoforms: ADH1, ADH2, which are in citric acid cycle, and we have also one isoform that is not mentioned here, IDH3, which is in peroxisomes in cells. Methylbutyryl methyltransferase, its mechanism of action is actually demethylation of methylated genes or promoter regions. So, for example, if methyl MGMT works, if for let's me give an example. We have some mutation or some external effects that affects the gene of the cell by methylation. So by methylation, you can silence the gene, mostly silence, but also you can overexpress the genes. And MGMT is, you do it actually by alkylating guanine base. If you remember, there is adenosine, cytosine, thymine, and guanine bases in DNA. By alkylating guanine, MGMT can prevent it. For example, MGMT dealkalizes the cell and dealkalizes the gene and makes the transcription factors or the protein in the end normal as it should be. But the mutation of this can lead to overexpression or underexpression of genes and to let's say mutant proteins that are not as they should function. Now, from histologic and pathophysiologic standpoint, here are named some mutations that usually happen in classic type of glioblastoma, like chromosome 7 amplification, 10 loss, EGFR amplification, lack of tumor-suppressing protein p53, ADH mutations, as I said, expression of some other genes, Notch and sonic hedgehog signaling pathways. These are all that are expressed in classic type of tumors. As you can see, in mesenchymal type of tumors, there are different types of mutations: NF1 deletion, SPT mutation, expression of mesenchymal markers, genes or tumor necrosis of NF-kappa B pathways. Proneural types have also their characteristic mutations, like ADH, of course, TP53. They have expression of development genes, like written here. I will not go into detail of every one of them, and also developmental disturbances. Neural type also has overexpression of some neural markers, and as I said, we have a synaptic transmission disturbances and projections of axons. So this was histologic types, pathophysiologic and histologic types. As you can see, as I said in the beginning, the mutations are different. So if we look at current treatment modalities, as we'll talk right now, we have actually only one, but there are multiple plethora of glioblastoma from genetic standpoints. Surgery is, as us neurosurgeons, surgery is the most used if the tumor is accessible. So the first is after the patient makes an MRI with a contrast, we see the tumor as we can see here. As we can see here, and the main idea is to resect the tumor, the whole tumor if possible. But this is not the only treatment. Why? Because, as I said, there are local metastases still not spotted, as the tumor is very invasive into normal tissues. So after surgery, the patients usually go on chemo and radiotherapy. From chemotherapy, there is actually only one drug currently being used, temozolomide. It's an alkylating agent prodrug that acts on alkylating DNA. And the drug was actually first discovered in 1980 by Ashton University in coordinates with UK Cancer Institute, and it showed better overall survival of patients who are on chemotherapy after surgical resection. FDA in USA approved another drug called bevacizumab. He is a vascular endothelial growth factor inhibitor. It's a monoclonal antibody actually, and it is currently used if the tumor is resistant to temozolomide. So here are the mechanism of actions. So temozolomide is an alkylating agent, as I said, and very important is when I talked about at the beginning about wild type versus non-wild type. MGMT mutation is very, very important in glioblastoma tumors. If patient does have mutated MGMT, he has poorer prognosis than the one that does not have MGMT mutation. Because if the one does not have MGMT mutation, the alkylating effect of temozolomide on guanine base will be nulled by the enzyme. So temozolomide is a good drug, but as you can see in the subunits of glioblastoma, it may help some patients but not help others, as we want as doctors to help people. The other, as on the right side, we can see bevacizumab, a monoclonal antibody. It binds vascular endothelial growth factors and actually inhibits the signal pathway of angiogenesis, which is very important in all tumors, not just glioblastoma. The current treatment modalities of radiation treatment of glioblastoma is 60 gray in 2 fractions followed with temozolomide. So this radiation treatment can be done by a few types. For example, hypofractionated or radiation treatment alone are alternative for elderly patients, but what is used mostly is intensity modulated radiation. As you can see on the picture on the left, intensity modulated radiation is if some patient has local glioblastoma on, let's say, in frontal cortex. Intensity modulated radiation uses beams from different pathways with different strength, and these beams collide in the tumor region. The main side effect of intensity modulated radiation is, of course, the effect on other health tissues, since X-rays affect other tumor tissue, not just tumor tissue, but healthy tissue, or the brain, or the eye. So now we are going to new modalities of radiological treatment. So in the recent years, there has been development of new radiological treatments like proton beam therapy. So what is proton beam therapy? It is a beam composed of protons. The main idea is that these protons penetrate through the health tissue to the tumor, and they are, from physical standpoint, they show Bragg peak effect. As I will describe it later, the idea is that the main idea of new modalities for radiological treatment is to treat mainly tumor, but not to affect the health tissue. So proton beams actually have advantage of not affecting the health tissue. Let me show you here a video. I think everything will be clearer. I will maybe let me go around here. So
Yeah, we're not getting the audio. I don't know if you want the audio.
they can hear?
No, cannot hear.
You cannot hear. Okay, I will explain.
Okay.
Okay, as we can see on the video here, this is this is a proton machine that produces protons, and now the main idea is the conventional radiation therapy. What it does, as you can see here, it affects the tumor, but the health tissue before and after. And you can see with proton beam therapy, the Bragg peak effects mainly makes its effect on tumor and a little bit on the tissue before the tumor, but not on the tissue after the tumor. let me see. Okay, this is how the proton beam therapy is actually working. It's like you're having a pencil, so you are actually attacking the tumor on the way you want it to attack, on different slides of tumor. So the main idea, I will now turn this off. So the main idea is not to affect the healthy tissue. Here is how it looks on CT scan. The protons have their Bragg peak effect here. So actually, this is the area we want to our beams to work. If you look at X-rays for example, intensity modulated radiation, look at the area of the radiation that actually is affected. All the healthy tissue, but also the tumor. In this type, we mainly attack the tumor. That is why the proton beam therapy is better and shows better results than traditional X-ray therapy. The other one therapy is called carbon ion therapy. It is very similar to proton beam therapy, but since carbon ion is a heavier element, it actually has steeper lateral dose penumbra, which means that it affects the tumor deeper and the surrounding tissue a bit stronger, but also it exhibits the higher linear energy transfer, which means that it delivers the stronger radiation than proton beams. So this proton beam therapy and carbon ion therapies are actually a very good way of replacing the classical intensity modulated radiation, but with results that are even better or somewhere near IMRT. So actually, the newest research shows these therapies are even better. But also, there is not enough scientific papers describing it. But I believe it will be. There is already in some centers using proton beam therapy and carbon ion therapy. And when I talked about Bragg peak effect, this is the graph that shows Bragg peak effect. So this is the radiation dose. As you can see, when using X-rays, healthy tissue gets its X-rays. The tumor also gets X-rays, but less since it loses energy through distance. And the healthy tissue after the tumor also is affected. When we have proton beam therapy, for example, we have healthy tissue affected, but this is the Bragg peak effect. So actually, we are affecting with radiation tumor the most. And we can see that the healthy tissue after the tumor is not that affected. But this is why the Bragg peak effect is very important, because it helps not to damage other healthy tissue. This slide actually shows how the carbon ion therapy works, as it is an isotope and it emits, when colliding with tissue, a positron. A positron annihilates and produces two gamma rays that actually affect the tumor. The idea is very similar. Let's say the carbon nucleus has stronger effect, but also proton beam therapy and both carbon ion therapy are very good for treatment as new radiation modalities. Now we will go to the new modalities of chemotherapeutic treatment of glioblastoma. So as we know, the current treatment modality is temozolomide. But there are also tumors that are mostly come back after the treatment of temozolomide. For example, the ones with MGMT, wild type and non-wild type, and the other genetic mutations. So there has been an approach on genetic basis how to treat these tumors. The main idea is the following: we discovered the new pathways of tumors. For example, like this EphA3 receptor, that if activated sends down the cell the signal cascade like a message to divide and to make angiogenesis. So a humanized version has been developed of blockage of this receptor called ifabotuzumab. It is currently in phase 0 and phase 1 clinical trials, so we actually don't have any substantial evidence or results that we can say, aha, this is the drug of the treatment that will be approved for chemotherapy. As I believe we have all heard, epidermal growth factor inhibitors, they actually work by inhibiting the epidermal growth factor ligand. So in this type, we have erlotinib and gefitinib. They are also currently in phase 1 to phase 2 clinical trials. They have shown very good results in vitro, but they are still to be tested in vivo. So these are also therapy that can be. This is also therapy that can also that can be promising. Monoclonal antibodies, rituximab is also an AJFR inhibitor, and it is already being developed, but it is currently also being tested, and we will see it might be combined maybe with bevacizumab chemotherapy, so there might be some correlation with these two drugs working together. Currently, for example, FDA approved irinotecan with it is an other chemotherapeutic with bevacizumab, but they have too much toxicity to the patients. So currently, bevacizumab is mainly used or by doctors now. Vascular endothelial growth factor inhibitors. So as you saw from the previous slide with the picture, Vagf inhibitors, there are two molecules that are developed in these types, tivozanib and pazopanib. They are currently in phase 2 studies. The main effect is actually to block the receptors, VAGF receptors, and inhibit the signal progression in the cytoplasm and to the nucleus. They are currently in phase 2 studies, and they have not shown that much results like bevacizumab, which blocks the ligand, VAGF ligand. For example, also another pathway was discovered, PE3K pathway inhibitors. PE3K is a pathway that is mostly affecting by phosphorylation system down signaling of the cell. And it is very expressed in glioblastomas, and its new research shows. And the main idea is also to block this kind of pathway. So we have a drug also developed currently in trials, buparlisib. Well, in recurrent glioblastoma, his effect has been minimal, but in primary glioblastoma, it showed some effect. So actually, this is also an ongoing investigation. Will this drug help us? Now, hepatocyte growth factor and MET inhibitors. This is another pathway. So as you can see, the main idea is to find which pathways or signaling models affect the glioblastoma, and human growth factor MET hepatocyte growth factor and MET inhibitors are actually just also one of the type. It is usually worked by dimerization of receptors on the cell and transmission of the signal down to the cell through phosphorylation. And here is the monoclonal antibody amuvatinib that is actually an inhibitor. It's a small molecule inhibitor. It affects on multiple tyrosine kinases. Why? Because the AHFR MET inhibitors are mostly sending their signals down through tyrosine kinases. So this is an example, a picture. So I did not want to go into detail because it is very complex to name all the proteins and what happens. I want to show the main idea. So actually we have one receptor, okay? We have one receptor that these two receptors are, let's imagine them divided. So so actually they come together, they come close, and that's called the dimer. And then this factor affects them by binding on the receptor. This activates the tyrosine kinase pathway, which causes the phosphorylation of certain molecules or certain proteins. So phosphorylation of these proteins, and you can see these are right here, sends down the cascade signal to the cell through multiple pathways, like mTOR pathway, which is quite known in the cell biology, and MAPK pathway. So we can see mTOR pathway affects cell survival, and MAPK affects cell proliferation. So these mutations can happen from too much hepatocyte growth factor ligand. They can be, for example, also mutations in this part of the receptor, which activates constantly phosphorylation and constantly sells down to the nucleus the message to the cell to divide and to survive and to cause angiogenesis. So when we use all these molecules I talked about, we try to affect some specific pathway of certain cell signaling mechanism to inhibit the effect. Now, before I go to tumor treating fields, I believe these are drugs that we use. We can affect some part of the signaling pathway, but I believe as recently there was a Nobel Prize awarded for CRISPR-Cas9 system that actually manages us to affect the genome of the patient, which is quite interesting because then there might be a possibility of repairment on the genome level, on the gene level, which is the main level where the problems actually can start. Now, tumor treating fields. This is a totally new field of therapy for not just glioblastoma, but for all tumors. What is the main idea for tumor treating fields in glioblastoma? So, as we know, not just glioblastoma, but all tumors. As we know, when cell divides, it goes through some phases like prophase, metaphase, anaphase, and telophase. Tumor treating fields actually exhibit a dipole moment, which is very important because the cells that are in division process, like metaphase and anaphase, have tubulins like septin 2, 6, and 7, which possess a dipole moment, which is very important because then these cells can be affected by electromagnetic field. By affecting, I will show you, I have a picture here, okay. By affecting, for example, the dipole moment of these septin molecules, we can catch the division of the cell, of the glioblastoma cell in metaphase or in anaphase and make it that tubulin molecules actually can't divide the chromosomes on two equal pathways, which makes the cell arrest in mitosis, and then it goes into programmed cell death. Or if division actually happens, it is usually an abnormal division. For example, one cell can have 5 chromosomes more than the other, and that is actually non-functional tumor cell. So this is actually very, very new type of treatment that has some promising results, but also is yet to be more studied and more scientific papers to be written about the subject. Very interesting is that this tumor treating field was developed by an Israeli professor and a researcher who then went on to start his pharmaceutical company. So this is how the device looks. This is the device that produces the field, and this is what the patient needs to like a hat on a head. He needs to have it like a hat on a head, and mostly the whole day. The idea is that he has to have it the whole day so we can actually arrest the glioblastoma cells in their division moments. There are promising actually results for this type of therapy because it is a concomitant therapy with temozolomide and standard radiotherapy. And we can see that actually overall survival was greater than 39 months, which is quite significant because if we look at overall survival of the patients with the glioblastoma is from 12, 13 to 17 months. This is actually quite a big improvement. Only adverse effect is scalp dermatitis because you put it on the scalp, which actually can be treated with topical corticosteroids. And also one very interesting fact that I found was that there were 2 long-term survivors, one that lived 84 and the other lived 64 months after their initial diagnosis. So actually this is quite, from my point of view, quite a leap in the treatment of glioblastoma. Well, the last, some say new treatment modality, some say not, but is called laser interstitial thermal therapy. It was actually first discovered in 1983. So if it was first discovered in 1983, why haven't we used it later? Well, actually, it was because of the lack of magnetic resonance imaging technicalities. For example, when MRI thermography was introduced, then the laser interstitial thermal therapy could be used more precisely. So the basics of effect of laser interstitial thermal therapy is that it uses heat to produce coagulative necrosis in the tumor tissue. When it does that, it uses, we can use the degrees from 50 to 100 over 100 and use coagulation and carbonization. But the main idea is the denaturation of proteins, cellular membrane breakdown, and enzyme induction. When it affects the tissue, it usually affects it from three zones. The first zone is the zone where it is actually where the heat is the strongest. The second zone also causes coagulative necrosis, but the heat is not as strong there. And the third zone also still has some viable cells. So I also found one interesting video that can actually show you how this works. I will explain it. As you can see, we have, let's say, some kind of a probe that we put into tumor. Let me just say, this therapy is mostly used for the patients that have tumors situated in non-operative areas. So this is the idea. You see, as you can see, we use tissue carbonization in this direction. Then what we do, we use on the other side, and we go through the whole tumor. This is not the newest treatment modality, but I put it because it is very important for the patients that actually cannot have surgery, and really it does make an overall survival better rather than not having this type of treatment. In Croatia, this is a small town from where I am from, Našice, with beautiful castle. And in Croatia, the current treatment modalities are chemoradiotherapy with temozolomide and standard radiation treatment with X-rays, of course, after, if possible, surgery. Actually, we don't have or use proton beams or carbon ion therapy, nor do we use bevacizumab, for example, that was approved by FDA. So our usually survival rate is 15 to 17 months for patients. Thank you very much for listening to me. I hope if you have any questions, feel free to ask me. And this was my presentation. Thank you.
Thank you very much, Ivan, for making this incredible presentation. I think you invested a lot of studying and preparation for this. I mean, just the sheer amount of facts you presented, and I mean, the abundance of data that you gave us is really remarkable. So I know that you have been investigating these tumors for quite a while. I mean, it's quite a topic in neurosurgery, and I could even say that it's one of those diseases that we all hate. It's just young population, people who have, like, in the prime times of their lives, and so little can be done. But you are also an economist. I mean, a graduated economist. So I would like your perspective on this. I mean, how does this all cost? Where are the cost-benefit analysis lies in this? And I mean, what are your thoughts from this standpoint? I mean, what do you think is the best treatment, and how would you think about it? I mean, briefly, if you can just introduce us to this process of thinking.
Let me just say, when I was researching the subject, the main problem for all these patients is that we actually have only one drug that affects the DNA on one way, and but you actually have glioblastoma, which is a plethora of diseases. You know, you have this mutation in mesenchymal type, you have this mutation in neural type, and then we attack it with one chemotherapy agent. So that is the main problem in treatment of glioblastoma. We actually do not have enough drugs, enough ways to attack the tumor. And from economic standpoint, well, I believe it really represents an economic challenge. because, as you know, chemotherapy is very expensive. What one should do, one should calculate, okay, how much do we lose when some patient gets glioblastoma? How much money do we lose from him not working, from treating him with chemotherapy? How much does it cost? And then what can we do to prevent it? Maybe there are some ways how we can catch it early on, you see. But it is very, very hard to answer, because if you look at from epidemiologic standpoint, you don't have a clear cause of glioblastoma. There are, for example, the people who use non-steroid drugs like ibuprofen, they actually are less likely to develop glioblastoma. The only correlation that was found was with the patients that are constantly induced by radiation. So actually, the economics is quite hard to answer, because you need to know how much all these chemotherapeutic drugs affect. I made a few years ago, I made a scientific paper that was published in USA, and the main idea is to see how much actually drugs do people throw away. You see, what we did was we collected drugs that were disposed from patients from 50 pharmacists in the area of Zagreb, and the cost of these drugs were around 80,000-90,000 euros. Only 50 pharmacies in Zagreb. So there is medicine is very expensive. What we can do is actually we can find more ways to be effective in managing of healthcare system, healthcare hospitals, and then we can find ways to treat other patients with this chemotherapy. Then the money can be found.
Yeah, well, it's really interesting. I mean, I remember we had these talks on various subjects in neurosurgery as late as last year's lockdowns all over the world. And I mean, it's really interesting how the world has changed. So I think this will also have an impact, I mean, as well. And I mean, also, we are getting lots of input from our panelists. I mean, people are watching this video and they're all saying thank you for the remarkable presentation. But also, there was this interesting comment, a great presentation by Dr. Bosniak. Cell nutrition can be a good clue besides genetic information to prevent all kinds of tumor.
Oh, yes. I didn't go into that subject. Sorry for interrupting you, but it is very, very interesting. Why? Because I was actually researching the cell nutrition and the probability of, how to say it in English, slobodni radical. Do you remember? Do you know the English?
Free radicals.
Yes, free radical. The free radical effects on the cell. And cell nutrition is some biologists here from our Ruđer Bošković Institute are pro vitamin C, which is okay, very interesting, because he catches free radicals in the cell. So if we are interested in cell nutrition, we should mainly be interested in catching free radicals, because they are the ones making the damage. But also, what has been recently or a few years ago discovered is if you put too much vitamin C into cell, you actually make free radicals go even worse. So you actually have more free radicals. Mm-hmm. So it is very interesting field how can be done. But I believe, yes, the mainstay of future approach of glioblastoma treatment should be on the cell effect and on gene effect.
Mm-hmm. Yeah, well, we also have this interesting, I mean, this question we got is kind of leaning on something that I asked you already about the economics, and also about the another thing I wanted to ask you, which, I mean, you've done your extensive study of this matter in the past time. So in your opinion, among the newer modalities for the treatment of glioblastoma, which do you regard to have the better outcome? And is proton beam therapy better than BNCT and PBFT? And about the affordability of the newer modalities treating glioblastoma, this is the question by our panelist, Gyatim Lakshmi. I'm sorry for the pronunciation of the name.
Well, I believe from my research that Tumor Treating Fields might be quite promising. Why? Because if you put these on head, actually they have an effect on the whole brain. So as we know, glioblastoma has its local metastases, and actually we affect all of them. We affect the division of the cell in wherever the tumor is. And I believe that is that will show, because as you can see, there were some TED Talks. You can also, for anyone who is interested, there was a TED Talk by the inventor of tumor treating fields, and what he actually, he has some patient, he was Olympic gold medalist, I believe in 1980, and he's still alive. Somewhere around, that is 7-8 years after the initial diagnosis of glioblastoma. And I believe that the proton beam therapy is the best, maybe carbon ion therapy, but you see, carbon ion therapy damages the nucleus more. So by damaging the nucleus more from tumor tissue, it probably damages the health tissue, the nucleus more. So I would maybe choose proton beam therapy with the other modalities.
Yeah, also one interesting topic that was, that was talked about, I remember already, but this is the topic of oncolytic viruses as treatment. I mean, what do you think about this role? This was also promoted by our viewers.
Yes, oncolytic viruses, or for example, retroviruses that can be induced in the tumor cells. Well, this was very popular 10 years ago, but since there has not been found a way to affect only the tumor, and also these type of viruses can cause other mutations. Your idea, for example, in retrovirus treatment, is to put the genome in the cell and do what your genome you want him to do, but you don't know in which type of gene or in which part of chromosome the virus RNA will be implemented. So actually, it can produce good effect, but it can also cause mutation. What if it happens in some important regions for example, P53 tumor suppression gene? So the idea is very good, but there is some small parts that need to be.
Exactly. Yeah. This reminds me of the gene therapy. I mean, with vectors that was started, and then it resulted in really catastrophic results with multiple deaths.
Excuse me, Slaven. I think Takashi, a neurosurgeon from Japan, has a question or comment. Excuse me for interrupting, Slaven.
Thank you. Thank you. I'm Dr. Kon from Tokyo, Japan. I'm specializing in GBM. So thank you for the great lectures. So during the Japan and Croatia, so some medical environments are different. So what kind of TTF? So in Japan, so some patients refuse to put all the cells hold the scalp. So it's very difficult to continue TTF. Some patients quit, and some patients refuse, and sometimes skin problems. So are there any problems to continue TTF other than health insurance, other than cost? So in your country, what kind of how you continued perform TTF for the patients of GBM?
Thank you for your question. Unfortunately, we don't use TTF in our country.
Okay.
Yes, we use chemotherapy and radiation therapy. We actually don't use even proton beams. This is, I believe, due to I wouldn't say financial situation, but healthcare is probably very costly, and our healthcare system is different than in Japan, different than in USA. The population is smaller, and we don't unfortunately use it. But I believe it is. Do you use it in Japan?
In Japan, TTF is health insurance, covers the health insurance. And we usually use the temozolomide and Vagf for the chemotherapy. But those are very expensive, but sometimes cannot afford to pay for the cost. So that's also a problem.
What is the compliance of your patients for TTF fields? Are they very compliant?
Male patients are very compliant, but female patients sometimes refuse to cut all the hair using wigs. So this is a very obstacles to continue TTF.
Yes, so I would also like to thank you, Doctor, for your questions. I would also like to ask our other panelists, do they have any questions? Because we were reading mostly the chat comments, and now is the time to ask if you have any. Thank you. Thank you, Dr. Takashi. If not,
Thank you.
we are going to, please, if you have any, just interrupt me and you can start asking. In the meantime, I will go to our chat to see if we have some other questions. Even if you're ready for some more, we have two more questions, which are.
Definitely.
So, how many times for radiation, main cycle for radiotherapy, from Mohammed Al-Zaini, which was asked in the chat before.
Just a second. Can you read the
Yes,
question again? Sorry.
how many cycles of radiation therapy? That was basically the question. Also, radiotherapy. How many cycles do you think are recommended, or have you found in the literature?
Where the oncologist I talked to, he says 2 cycles.
Two
But
cycles.
also you need to see how is the patient progress. Does the glioblastoma progresses? Is there more cycles needed? For example, with the first cycle, temozolomide is usually given, and after that, radiation is stopped and temozolomide is continued. But every patient needs to have its unique approach. This is actually the modern medicine. Every tumor is not the same in 2 patients, and every treatment modality should be different.
Exactly.
As I said, if someone has or has not MGMT mutation, the prognosis is very different. It is only one mutation in the tumor.
Yes. Well, I'm also waiting for giving some pause for the panelists to come in if they have any questions. But there is also this interesting comment from Robson Amorim. I'm sorry again for the pronunciation. Great presentation, Dr. Ivan. Treatment with TT fields seems to be very promisable in terms of survival. Why is it not a widespread treatment among neurosurgeons? Costs and feasibility. I mean, this has something to do with your discussion with Dr. Takashi, but if you could just wrap it up a bit.
Yes. Well, I believe because some neurosurgeons are mostly focused only on operation, and then they give the oncologists and the other doctors TTF fields focus, But I believe the cost is the main problem why it is not currently used. If you, for example, look, you have a promising therapy that could prolong life of a patient, not only 5 months, more, 10, 20 months. But it is still not used here in Croatia. So my main message would be maybe probably the economic cost is probably too high. There is, as I know, I have not only one firm, as I know, produces them. I may not be right, but from what I know, only the professor from Israel actually, who has now his own pharmaceutical company that produces tumor treating field, does it. So probably the price is there. Probably there is still not enough years past, so we can say, now this is a current standard treatment modality.
Yes, well, I think there were really lots of questions. I mean, they are incoming also. I just thought that this was it, but it seems that we have another question. While treating with TT fields, what are the ways we can measure the TT field response?
You follow the patients by concomitant MRIs. You can see if the tumor is shrinking because you induce apoptosis, actually. So maybe what is very interesting that I have not mentioned with proton beam therapy, it makes, by destruction of the tumor cells, it sensitizes the immunological cells to attack the tumor. So also TTF fields do the same. If you induce the apoptosis, you induce the cell death, the tumor material is out. If the mutation is inside the cell, the immunologic cell might not catch it, but now you have a membrane rupture and the immunologic cell can catch the difference between the normal tissue.
I'm really amazed at how deeply you studied this subject, and really thank you for providing so much input to our panelists and viewers, because it's really, I mean, it's such an important topic, and I believe all of us would give like all our strength if we could do something about it. There is also we have William Flores as the biological therapies improve outcomes as survival-free tumor or all survivor. Where does the biological therapy improve outcomes? As tumor-free survival or overall survivors? And what are the adverse effects of this biological therapy?
Well, we have two distinction terms: progression-free survival, that is the time from drug diagnosis, from starting the treatment, and overall survival is time to diagnosis to time to death. So actually, when we use drugs, our main idea is to have progression-free survival increase and overall survival increase. So this is the same train in the two stations.
Yes, and also by Tokir Akhmediev, there is a question. Thank you for the presentation. What is the most survival time in the case of glioblastoma multiforme? This is an important topic.
Yes.
Can you pronounce that name again, Slaven, please?
Akhmediev, I think. Just a moment. I'm really sorry. I don't know if I pronounced your name correctly.
That's okay. That's okay. That's fine.
Tokir, yeah.
What is the most survival time in the case of glioblastoma? From the literature, I have read 84 months.
84 months, yeah. So it's basically how much would that be in terms of years?
7 years, something like 7 years.
That's actually a lot.
That's actually a lot, yes. So when you look here from 12 to 15 months to 80 months, that is quite a leap.
Quite an achievement. I mean, and do you think that this survival time will go up as we progress in treatments?
Yes, I believe definitely that in the long term we might make it a chronic disease, but the idea how to affect the tumor is very hard. If you have, as I have mentioned, with all these pathophysiological and histological types, you have to differentiate neural from mesenchymal type, and the therapy for these types has to be different. If you have only hemodal, actually you are trying to attack something with the same weapon, if you know what I mean. But that something might be a soldier or a tank, if you understand.
Yeah.
So actually, what my opinion is, this tumor treating field is good because it affects on physical level, on physics. You know, affecting on physics is affecting everything. But if you look at chemotherapeutic level, you kind of try to hit certain pathways. If you have 50 pathways, that is very hard because, as I mentioned, if you give bevacizumab and irinotecan, you have pretty much more side effects. And that is why chemotherapy is good, but maybe this is the future treatment.
Yeah.
This type of treatments. It doesn't have to be tumor treating fields, but this kind of understanding, maybe like cellular immunology, impacting the cells to see the tumor before it develops. You know?
Yes.
Like vaccines. Maybe this is because you give the body the ability to kill itself. This is hard to make 5 chemotherapy drugs that actually do what you want without many side effects.
You know, I'd like to make a comment, Slaven. Excuse me. One of the things that Slaven said at the beginning was the lack of progress in treatment of this disease, and I think most people know that one of the keys is artificial intelligence and the Chinese community at getting trials that are huge, have huge numbers, and that can be done in China. I think we're just starting to integrate into the China. Matter of fact, we had a program, we had a big Chinese neurosurgeon that wants to collaborate with a US-based artificial intelligence research program. Once we get into the Chinese community, once we get the numbers, many feel that we'll make progress. What do you say about that, Ivan?
I definitely agree. The more patients, the more ability to test, of course, the larger the cohort study group. We can definitely have better results. All these tests, for example, the chemotherapeutics, as I said, in vitro. I mean, if you expose the tumor cells in vitro with high doses of vitamin D or vitamin C, it will die. But this is not the same in human being or in an animal. So these type of, I believe, studies will, especially the Chinese, will give a lot of value to the treatment of glioblastoma.
Okay.
Wow,
More-
I think this was really intense. I mean, Ivan got questions from all sides, and I think you really studied this subject, and we are all grateful that you provided us with your insight.
Yeah, any
And,
more questions, Clark? Any more in the chat? We have time, Slaven, if you want,
Sure.
guys want to roll. We have time. I mean, this is great. This is great. Any more questions or chat questions from the panelists? This is great using the chat. You're doing a great job, Slaven, getting those chat questions.
of course, yeah, because I mean, people are running around. It's different time zones around the world, and it's great if we can provide them with some info. I mean, especially for someone who's knowledgeable.
Okay, I guess if there's no questions in chat, or biological therapy, did you get that question? You did that question.
We
Okay.
covered that one too. Yeah.
Okay, great. I'd like to, Saeed, do you want to make any comments? Saeed is a neurosurgeon from off the coast of Africa. He may have stepped away. He probably did. Takashi, thank you very much for coming. Takashi does Japanese translations, Slaven and Ivan, for neurosurgical presentations. He does translations for us. It's good to have a neurosurgeon doing the translation. As you know, the language is different. Anyways, great great start to the Croatian channel.
Thank you.
And we look forward to continuing with both Slaven and Ivan. So, okay, we'll end this right now, and thanks. Stick around to network. Thank you.
Thank you. Bye bye.
Right.